So I'm just going to show a case. I was asked to fill in. I think the person I was going to present wasn't available. But this is a 61-year-old woman, history of hypertension, prior CVA, Crohn's disease, had multiple prior MIs and multiple PCIs, and had some chronic heart failure. She was admitted to an outside hospital with a non-ST elevation MI again. Her heart function was reduced. EF 28% was high. Honestly, it was probably closer to 15 to 20%. Had moderate to severe MR. However, her renal function was normal, and initial presentation of troponin was normal, but then was elevated mildly at around 3. Her initial angiograms here showed a mid-LAD. It's a very focal stenosis right at that large septal, a sort of a napkin ring lesion. It doesn't project as well. Right at the first septal, and there's distal left main disease as well as proximal circumflex disease. Iliac axis was okay, and her baseline hemodynamics, although she initially came in hypotensive and required some pressors, by the time she got transferred into the cath lab on a little bit of dobutamine and vasopressin, she was stable. Her filling pressures were low, actually. Her cardiac index was 1.8, and her aortic pressures were in the 90s to 100s, systolic with a MAP in the mid-50s. So she was actually in the randomized trial for Impella versus balloon pump, and randomized to the Impella device, which was placed transfemorally. And to comment, it's fairly quick and easy to place. It's simply putting a pigtail in the LV, exchanging this over a wire, and usually use a Roadrunner wire or sort of a 018 wire, nitinol wire. The current device that we use primarily is the Impella 4.0, which provides up to 4 liters of support. And as you just heard, it's basically an axial motor that sucks from the LV and injects into the aorta. The Impella 2.5 goes through a 13 French. The Impella 12 French Impella 4.0 goes through a 14 French. So slightly larger sheet size, but a significantly better cardiac output, 4 liters versus 2.5. After the insertion of the Impella, again, her hemodynamics were good to start. Her PA pressures were low, and see her aortic pressure. She did fine with the LAD intervention. And what happened is during attempts to wire the left circumflex, it was a retrograde takeoff of an angle. And the left main dissected in the circ, and you see here she has no flow in the LAD into the diagonal and very slow flow into the LAD. So whole distal left main LAD is dissected, and the circumflex has no flow. So the entire left circulation is compromised. Her RCA was okay, and her RV was okay, and I think that was the only thing that saved her in this case. She started to complain of chest pain, and her systolic blood pressure dropped. The flow rates on the Impella were turned up. Right now, the console then was different, where you manually dialed up the flow that you wanted. Right now, the console is automated, and it will dial up to the maximal flow. And what's sort of fascinating here is, if you look at these tracings, this is not her aortic tracing. This is her PA tracing. Her PA pressures, which were around 20, climbed to 45. And her aortic pressure became a flat line, essentially. There was no pulsatility to it, and it was a mean pressure of around 55. It had been about 90 over 40 with good pulsatility, and now her aortic pressure has no pulsatility. But what's fascinating is she wasn't a large woman, so even though it was a 2.5 liters of support, even without any cardiac output, essentially from the LV, the Impella was able to maintain enough perfusion for her to continue to mentate throughout the case. So eventually was able to wire the LAD in the diagonal, and ended up having to stunt it essentially from the proximal LAD across that diagonal. You see the diagonal is a little bit pinched, and ended up using a mini crush technique at that time, mainly just to make sure that I got good coverage and that we maintained flow. And then in looking at it further, there's disease all the way into the left main on IVUS and dissection. So put a stent LAD into the left main here, as you'll see here. And got restored flow and reasonable flow. And you see good flow into the LAD, the diagonal. Circumflex has flow. There's still an osteal lesion, but at that point decided to leave it alone. The Impella was weaned off, and at the end of the case, patient hemodynamics improved. Her aortic pressure here Actually, she had gotten a fair amount of pressures at the time to maintain her mean pressure, but at the end of the case, by the time she left the lab, her pressures were around systolic of 120. She was asymptomatic. The Impella was removed and closed with percutaneously closed with the ProStar device. Her PA pressures were more elevated than at the beginning of the case, partly because once she became hypotensive, she got a lot of volume. So her RA climbed to as high as 20 from around 2 to 3. And I think over the course of the next couple of days, she was diuresed. You can see evidence of hyperperfusion and ischemia. She was very acidotic immediately after the procedure. Her pH was 7.29. Her creatinine climbed a little bit, but returned back down to normal by day 2. Her troponin, which had been around 2, peaked at around 6.4, but did not have a big infarct. Eventually was discharged on day 2. So it was a fortunate case for this woman, and the 2.5, although it's not generally adequate support for full flow for people, it's not like ECMO, we're going to provide full flow. In this woman who was small, she was 90 pounds, which probably about 40 kilograms. It was enough support for her, and actually without any pulsatility and essentially no cardiac output from the LV, she was able to maintain perfusion. As I said, there were some key differences. The reason it worked in her is her RC was okay and her RV was okay. If her RV failed or RV didn't work, this wouldn't have supported her because you wouldn't have basically gotten any perfusion across the pulmonary vasculature. And you need that to be able to get oxygenation and oxygenate the blood because there's no oxygenator. And that's a little bit different than obviously very different from ECMO, an ECMO circuit where it provides full support in those regards. But the Impella does decompress the LV well, and initially it was not as effective as tandem heart. And the tandem heart can be put in very quickly within less than 10 minutes, especially with people familiar with transeptal skills. It's a 21 French, as you heard, venous cannula, and really well decompresses the LV appropriately. But all these things trying to put them in an emergency setting is sometimes challenging if you don't have a lot of experience with it. So I think the key is if you're familiar with the devices, when you need it urgently, you can put it in quickly. Thanks. Any questions or?
Sushil, anyway, thanks for the nice presentation. One question, this Impella which you used is the older model or the CP? The newer model called? Newer model called Impella CP.
No, it was the LP. It was a 2.5 liter.
The reason why I'm asking is because we use the older model for cardiogenic shock cases, but we found a very high incidence of hemolysis in that.
Right. I mean, I think those are real concerns. There's the Impella 5.0, which is a 21 French surgical device that people have put axillary by sewing an axillary graft, sewing it in when people need more support. But I think now with the 14 French device, which provides 4 liters, I don't know if there's a real role for that 5-liter device anymore.
Yeah. So here the volume status is important. So what is your target CVP or RA mean?
So in this case, as I was showing there, she had been diuresed before she came to the lab, and her RA was 3. And once we put the Impella in and you turned it on, you start getting chatter because there's no volume in the LV. So end up giving fluid boluses to try and get her RA around 10, 8 to 10 at least, to provide enough volume so the device will work. If you don't, if your volume depleted, as it was in this case when we started, the Impella won't work.
How much do you keep the CVP generally? Target
around 10.
Pressure?
10.
10.
Yeah.
Thank you.
Now, and I was going to show a case. I didn't bring it because initially I wasn't scheduled to give this talk, but recently I've done 3 or 4 cases of high-risk PCI in patients with aortic stenosis with the Impella device, patients that were in cardiogenic shock with aortic stenosis. Although it's technically contraindicated in AS, the device works well for that. The tip of the device has a bullet shape, so even though you have a stenotic valve, it crosses. And especially with the 4-liter support, although you do occlude some of the aortic valve opening in the orifice, the 4 liters of support is more than adequate in those cases. So in some of these high-risk AS cases that are in shock, you can also consider using this device.
Thank you. Thank you.